started. My topic is small bowel, but within that it's a smaller section. So I'm supposed to talk about mesenteric ischemia and intussusception and something else today. And the next week I'm supposed to cover small bowel neoplasm. I took this pretty much from the from SCORE, which is the Savastin chapter, which is 90 pages long. So y'all have about a week dive into that. But my part of this is probably about 10 or 15 pages of that chapter. So I encourage you to spend some time on that. There's a whole big section about physiology and gut hormones and all that, which is terrible to read, but and I think not really practical knowledge for a general surgery resident, but testable knowledge. So we'll cover these, and I think obviously you should know how to take care of a patient, and a lot of this stuff that's covered in this section is kind of not when we see those patients. When you get called to the MICU with just a disaster or something like that. So I'll go through that and kind of contrast. It starts with intussusception, which seems to me to kind of be out of place in all this. But it kind of starts with that to kind of think about it in an adult versus a pediatric child, because really we don't see that much of that. We don't see that much mesenteric ischemia anyway. So anyway, I'll get started. So it's the Savastin chapter. There's a little bit in up to date, and I supplemented just a little bit with Cameron and all that. So, but I mean, the Savastin chapters, it's all in there, but it'll take you a while to get through it, and I'm just brushing the surface. So do not think that this is completely covered by this 45-minute lecture. All right, so intussusception is just, there's those two words, intussusceptum, and the other one, intussusception, however you say that, where the small bowel invaginates into more distal bowel. But in an adult, we don't see them, right? It's pretty much a disease of children. And when we do see it, it's from something else. There's some kind of what they call PLP, pathologic lead point. Children in general don't have those. And so actually, from my friend Dr. Maureen Heldman, they see intussusceptions on CT scans all the time that are done for something else. And they don't call them because that's not kind of in their spectrum of the disease they're working on at that time. So they happen and they reduce themselves and they're of no consequence for the most part. But occasionally, there's something in the bowel that is the lead point that drags that more proximal piece down into the more distal piece. So, these patients, until they obstruct, may have kind of intermittent symptoms where they'll have some abdominal pain with that, maybe some nausea, vomiting. Diarrhea doesn't seem like a symptom you would see in that, but you can because it's irritative to that piece of bowel that's being brought down in there, and it causes kind of a mucorrhea there that can kind of stimulate the rest of the bowel. So bleeding and obstruction you'll see, but those are kind of late findings, and that's when we're going to see them, right? When they obstruct and they come to the emergency room. In general, they're diagnosed on an adult with a CT because it's going to be somebody that's got the virgin abdomen that comes into the ER with a bowel obstruction. In children, always an ultrasound. You can imagine it's easier to wrestle a kid with an ultrasound probe and look at his abdomen rather than have him lay still for a CT for 45 minutes. Okay, and in an adult, something caused the intussusception, and in general, that's going to be a cancer until proven otherwise. And these people need a laparotomy, right? Because in general, it's not going to reduce itself. There's something that's holding the bowel kind of downstream, and it can drag down a fairly large piece, so you're going to want to try to reduce a little bit to limit the amount of bowel you're going to have to resect. The most common site is ileocolic. And there's actually an ileocolic one where it just invaginates further or something. But in general, it's going to be a cancer right around the ileocecal valve. All right, so of course, Dr. Richardson lectures, you're going to have to do some pictures. What you're going to see is the target sign. And so this right here is really nice where it's kind of looking at it on in. So this is the more proximal piece that's brought through into the more distal piece. Right lower quadrant, ileocolic. And on an ultrasound in a child, we don't get these on adults because we just don't, right? You'll see the two pieces, and it's a target sign either way. Here it is in a reconstructed view, and this is pretty nice. You see the internal piece here and the more external piece. This is pretty dilated, so you got to worry about this perforating. But what actually perforates is not the outer piece, the more distal piece. It's the limit of the more proximal inside piece, because its mesenteric is so squished and crushed that this part is ischemic right here. What you'll see is a picture of a bowel obstruction. You've got contrast however far, and then distally no contrast. And here it is, just kind of a similar one. Contrast goes so far, and then you've got a bowel obstruction. Okay, so that's a a surgical emergency urgency. That's not going to reduce on itself. That's not something you're going to post for later in the week. That's got to go to surgery. Here's just some more pictures. So your proximal invaginates into your distal. Here's a real life picture of it. All right. And when you reduce it, let me go back. When you reduce it, you don't grab this piece and just pull them apart. It's like a Chinese finger trap, because what happens is the material that's in the bowel is going to kind of be dilated in that area, and it kind of pinches down, and you don't want to shear off the mesentery as you reduce it. So the way you reduce it is you milk it back. You kind of push on this part where it's not involved and kind of push it out this way. You may be able to get it to reduce, you may not, but you want to push it back a little bit. But if you start seeing changes here that are ischemic or dead or whatever, you just stop. I mean, you don't have to reduce it and then cut it out, right? If you get the dead bowel, just stop and resect that. But that way you're going to minimize how much you're going to have to resect distally and proximally. All right, so that's the way to do it. Push it back with your thumbs. So the pediatric intussusception is a different deal, and these are the people you're going to see. You're going to get called to see some kid in the pediatric in the ER with belly pain, and it's typically a little toddler, about 2 years old or so, maybe a little bit younger. And there's the seasonal variation where you see these kids in summer, viral syndromes. 95% of them are idiopathic, but there is kind of a lead point, but it's not really pathologic like a tumor or something in an adult. The other sources of this is a Meckel's, which doesn't make sense to me, just kind of based on anatomy. I don't understand how that necessarily intussuscepts or polyp. Children can have polyps too. But just about all of them are going to be ileocolic. So they'll present with colicky abdominal pain, probably some vomiting, because this is essentially a bowel obstruction. You may be able to feel that mass through their thin abdominal wall. And the rectal bleeding, but it's not like stool and blood. It's the current jelly. I got a picture of that too. And so they'll have severe colicky pain where they pull their legs up, and they may be kind of listless or even quiet in between, but it's really kind of obvious what's going on. Okay, so there it is. It's not stool in there, it's not just frank blood, it's kind of mucus and stool, because that mucosa that's being squeezed in the intussusception, the intussusceptum, is like secreting mucus, so that's irritative to the GI tract, and so that comes on out. So you'll have kind of a bloody, mucusy bowel movement. See, there's not really any stool in there, and that's not just frank blood. So what the lead point is commonly in children is lymphoid tissue in the most distal ileum, okay? And so what happens is, you can see on these, maybe that one, you can kind of picture it up where peristalsis gets right to kind of start dragging that in and invaginate this mucosa and on. And, you know, these don't look like much here. It's not the best picture in the world. However, if kids got a big viral syndrome going on, these are going to be much bigger, right? They probably didn't have a viral syndrome at the time they had the scope to take this picture. So these are probably pretty small right here. But what it is that kind of pooches up into the lumen, and it's a point that the peristalsis can kind of grab and drag further. But the two viruses, I could see this showing up on the test. The two viruses that are associated with intussusception are, number one answer is adenovirus and maybe rotavirus too. Okay. Peyer's patches in the most distal ileum. So here's kind of your sequence. It's not really a vicious cycle because it doesn't cycle back around. It's kind of a linear thing. Regular prograde peristalsis. The proximal bowel invaginates and pulls its mesentery down into the recipient bowel. And so that squeezes and compresses mesenteric vessels, the veins first, which causes edema, and you get venous compression, which can lead to interference with arterial flow. Okay, so it's an obstructive problem that gets to the point of an ischemia problem. Okay, diagnosis. KUB may not be helpful. It may show a bowel obstruction in a child. If you happen to have a KUB, you may be able to see kind of that sausage piece of bowel. But ultrasound in kids, that's what you get. It's non-invasive, it's cheap and easy. You can get an ultrasound on a kid that's fighting better than you can get a CT on a kid that's screaming and moving around. I talked to Dr. Boykin. I'm not sure exactly what they use here, but I think it's the contrast enema to reduce. And he says that's kind of where you work dependent and which radiologist that's on call to do it. Some use air, some use water, but here they use contrast. And I mean, that makes sense. They can kind of watch it. And what you'll see, I used to have to do pediatric surgery before these guys came in. Thank God they're here. But you'll see it. You see it, and you see it kind of push, and it'll push, and then there's kind of just that, right on the edge, and then you see it flush into the small bowel, and you know you're okay. But it's very satisfying to watch them do it because you're like, yes, I don't have to go operate on this 2-year-old. But anyway, but a surgeon of some sort, maybe a resident, needs to see that child to say, okay, they don't have peritonitis. I don't see any free air. He's not fixing to be in shock or anything to where we can attempt that reduction. Okay, so it's the old, what do we operate on people for? Sepsis, perforation, obstruction, bleeding. And if he doesn't have any of those, you can attempt reduction. Okay, so the rule of threes, I had forgotten this because it's been a while since I had to deal with this. But these are kind of more for the radiology side, and this is kind of how do you know when to stop with your reduction. And again, if the child is unstable or has peritonitis or you saw free air on some of your earlier studies, you don't fool around with this, you go to surgery. So the rule of threes is 3 attempts, 3 minutes duration per attempt, in the enema bag about 3 feet above the table in the child. So operative reduction, if the child's stable, you don't have to take them to surgery expecting to do a resection, and you can't reduce it radiologically, you'll take them to surgery. So you milk that intussusceptum back with your thumbs like you did. Don't just pull it apart. And it seems to me you just reduce it and walk away. That'd be hard to do. But I mean, those that I've dealt with on this, that you couldn't reduce it, so you ended up resecting it. So you end up resecting the distal ileum and the cecum, and the appendix comes with that. But if you can't reduce it, then you have to do resection, obviously. But there is the possibility of just reducing it manually, operatively, closing the child, and that's it. There is a recurrence rate if you just reduce it, up to 20% with radiologic, which seems very high. But if you do it open, it's only about 3 or 4%, which would just make you feel terrible that you've lapped this child and he's got a recurrent intussusception within just a few hours or a few days. But the literature says that if they have a recurrence, it's going to be in the first couple of days, and they're easier to reduce because the parents are more aware of those symptoms and they're watching the child, so they'll bring the child back sooner before they have so much bowel wall edema that'll be easier to reduce. Okay, so there's a fairly high rate of recurrence with radiology, lower with open. Of course, there's none if you have to resect, but it's okay to have to re-reduce it by whatever means. All right, so that's all I've got on that. That took too long. But the other topic in this section for today is mesenteric ischemia. So there are 3 kinds. There's embolic, thrombotic, and nonocclusive. So we're going to go through those. And in the end, they're kind of the same for us because what we're going to have is dead bowel. You're going to be called to see a patient with acute abdominal pain, pain out of proportion to exam, and they're going to have some dead gut. Now, there's some things you can do to maybe save it, but probably not. Usually there aren't a lot of findings until it's a disaster. Okay? So just to remind ourselves, the anatomy, SMA comes off the aorta. First branches are the middle colic. Then you have all the small bowel branches, and it ends over here at the right colic artery. Okay? So it's nice. The small bowel is pretty forgiving. It's got a nice collateral circulation, but they're all coming off the SMA. So it's great until you knock off the SMA. So an embolus is a piece of clot that came from somewhere else, usually in the heart. Something's going on with the heart, and it falls into the SMA. And the SMA is a better kind of target for that embolus because the celiac and the IMA, the takeoff of the aorta is a right angle. So the SMA is an angle, so it just falls down in there. And so what happened is the clot is going to dislodge and go some distance down the SMA. Thrombosis is a vascular patient that's got disease everywhere, in their carotids, in their coronaries, in their peripheral vasculature, and they clot off at the ostium of the SMA. So that matters kind of in terms of how you're going to find this patient. Is an embolus is going to be kind of a bad heart patient coming from something else, but the thrombosis is they may have a chronic ischemia and they're suddenly clotted, so it's an acute on a chronic ischemia. And the pattern matters because hang on, I'll go back to that. But anyway, this was actually one of my oral board questions. They gave me a patient that had acute onset of abdominal pain right after a heart cath. And so you've got to describe that, you're going to go resect bowel, second look, how you do an SMA embolectomy and all that. But not very common you do the embolectomy because by the time you get in there to surgery, it's kind of damage done. You resect the bowel and you're out. Okay, so this is just a little bit more skeletonized picture. the embolus comes from somewhere else, so it's going to be more distal in the SMA. And so the first branches are the middle colic and some of the jejunal branches. So part of the middle colic will be all right, part of the transverse colon, and your proximal small bowel. Because if you don't get there in time, or this patient doesn't make it to surgery in time and they've got thrombosis at the takeoff of the SMA, the whole small bowel's dead. There's not much to do on that. You're essentially doing an autopsy. You know, you're figuring out what's dead in surgery, and this is comfort care. But you may not make it there on time. So it matters in terms of what's going to happen with this patient. I mean, this you're going to resect bowel. Hopefully these are not, if with the duodenum and the jejunum that's alive, you've got a patient you can salvage. But the entire small bowel is dead from thrombosis of the SMA. Patient's dead too. Okay, here's even a little bit more skeletonized picture. Got the SMA and the IMA, and the connection between those two is the marginal artery of Drummond. It's a little bit of a saving factor in those vascular patients that have chronic mesenteric ischemia, where hopefully this is developed and there's some collateral. But the SMA is just like, you know, a terrible accident. There aren't any collaterals. You knock it off here, and again, the small bowel has a lot of collaterals, but they're all coming off the SMA. Okay, so kind of back up again. The embolus comes from somewhere else, usually from the left heart, shoots down the aorta, down the SMA. And it lodges somewhere down that SMA. So your middle colic, your first branch up there is going to be spared. So that can kind of help you see what you've got when you have to take them to surgery. Hopefully some of the proximal small bowel's alive and some of the transverse colon, maybe all of the transverse colon. So the arterial thrombosis is, you know, your typical vascular patient. They've got carotid disease, peripheral disease, coronary disease, and they've got SMA disease too. So this it's an acute clotting off of that vessel at the SMA takeoff. So, like I said, it's going to be acute on chronic. And for these patients to have trouble, since there are these nice collaterals from the IMA and even the celiac, for somebody to have chronic mesenteric ischemia, in general, you've got to have two of those main trunks knocked out for there to be symptoms. And so they may have symptoms of food fear and weight loss and that kind of stuff. So the risk factors for both of these is kind of your typical vascular patient, okay? Smoker, drinker, hypertensive, hyperlipidemia. And the arrhythmias, so they've got an ineffective heartbeat that's got clot in there, and so they get that, you know, one good beat in their AFib and they flip out their clot. For somebody that's got an aneurysm, they can flip a clot down there. And these other test question stuff, but patients we never see, vasculitis and polyarteritis nodosa. We never see those. So kind of the buzzword is pain out of proportion to exam. And when you go see these people, they're writhing around in bed and you touch their abdomen and it's soft. Or they're gorked out on the vent and you don't know what's going on, right? So that if they could talk to you, they would describe an acute onset of abdominal pain, because I mean, like, ischemia is ischemia, whether it's in your heart, where you have acute onset of chest pain, or if it's in your abdomen. Metabolic acidosis, because you're running on an anaerobic metabolism in that GI tract. And if it's that vascular patient that has chronic mesenteric ischemia, they'll have food fear, weight loss, pain after meals. Okay, so invariably they're going to get a CT because they're going to come through the ER. It's going to be somebody in the MICU or RICU that can't talk to you and you can't get a reliable exam. And if they got perforation, free air, dead bowel, that's easy. They're going to surgery. What you can see to help you kind of decide which one you got, and again, you're looking for dead bowel. Okay, the vessel's kind of already done. An embolus, I don't have a picture of this, sorry, I looked, is you'll see an oval-shaped clot, that makes sense, surrounded by contrast. It's going to be downstream in the SMA. The thrombus will be a calcified takeoff of the SMA with the clot sitting right there. Okay, that's not helpful, but that's what you'll see. But pain out of proportion to exam is the buzzword and what you got to think about when you go see a patient or when you take a test. Rarely there'll be a patient with acute on chronic ischemia without symptoms of bowel ischemia, and you can observe them, anticoagulate them, and then do an urgent elective bypass. I'm going to defer to Dr. Vert to discuss that with y'all because that doesn't happen. I mean, when have we done a mesenteric bypass in this hospital? Once every 5 or 6 years. That's just not how we're going to see these patients. But for our plan, it's going to be damage control. You've got to take care of the infarcted bowel Ideally you would reestablish flow before you start resecting, and you might be able to resect a little bit less. But again, these people, it's a dramatic presentation, and you don't have time, and you're kind of cleaning up the debris afterwards. So you resect the bowel. If everything's dead, there's nothing you can do, and you plan on coming back to do a second look. And so we'll go down. So obviously this is a high morbidity mortality. These are not great patients to start with, and then they have something like this where they knock off a bunch of small bowel. And so the mortality is 50 or 60%, 50-50. And invariably they're going to have complications. That can be as simple as intra-abdominal abscesses that you drain with perk drains. This is going to be renal failure, just a disaster in the ICU. And again, they're sick before they had this insult, so only about a third of them are going to be alive at a year. Okay, so this is an intra-abdominal catastrophe in a disaster patient. So there are, and I would not answer this way on the boards, there are some endovascular treatments, but they're kind of, it's not conservative at all. It's quite bold to try to undertake this because you can't look at the bowel. If you happen to get there on time, or early and figure out what's going on, there are some percutaneous interventions you can do. You can do thrombolysis, maybe a balloon and stent. But again, you can't see the bowel to know that it's dead or at risk or anything like that. So I would not answer like this. Maybe if you're a vascular fellow or something like that and taking boards, you might be able to walk your way through this, but don't do that. And if there's any deterioration, of course, you've got to go explore. So how do you expose the SMA? This is on my boards too. You lift up the transverse colon, the transverse colon mesenteric, and you'll see the root of the mesenteric for the small bowel and the SMA there. So you dissect off your fat and everything, expose your SMA, tie off, or not tie off, put vessel loops or ramels or whatever around all your collaterals there so that you can access the SMA. And you do a transverse arteriotomy, right? So when you close it, you've got a little pucker there rather than narrowing the lumen of the bowel. But you pass your fogarty proximally and distally till you get clot out, till you drag it and you don't get any clot, and then you can close. But again, with an embolus, you're not going to be here in time. It's going to be downstream, and there's not going to be anything you can do. And that's just the same thing. Pass your fogarty proximally and distally, pull out any clot, and close your vessel. So nonocclusive mesenteric ischemia, this is like the worst one, because this is your patient that's already sick in the ICU from something else, and then they do this. So it's pretty easy to kind of figure out what's going on if you think about it. I'm pretty pragmatic in the way I think, and the way I take care of patients is homeostasis will sacrifice everything else to protect the brain and the heart. So it'll clamp down the periphery, it'll clamp down the gut to keep those two organs alive. And so if you're volume contracted and you're vasoconstricting the gut, that's okay for a little while. And I kind of like this that I found at the bottom. The gut can compensate for about 12 hours at 75% reduction of flow. That's a pretty good bit. That's a very decreased flow. And you can kind of think of that too in terms of a strangulated hernia or something, how much time you've got, maybe to take. Think of 6 hours of stuff with leg ischemia or something like that. But the bowel is pretty resilient to a point. But it's mediated physiologically by vasopressin and angiotensin, and we do this by giving people pressors. Sometimes we got to use them, sometimes we don't, but we can induce this. And again, you've got a just terribly sick person in the ICU that gets this. This is not somebody that walks in the emergency room. You're already sick from something else when you get this. And so, in general, in theory, it's easy to fix. But you've got this disaster patient that you just can't dump a whole bunch of fluid in. But you need to adequately hydrate so that they're not as vasoconstricted. Try to get off pressors if you can. And you might anticoagulate to limit thrombus. Now, in general, a general surgery patient or a trauma patient, anticoagulation, that's one of those risk-benefit things. You may not be able to use that. But we're a lot freer with hydration and blood products than the MICU is, right? How many times have you been called to see somebody in the MICU? They're on a bunch of pressors and their hemoglobin's 7. You're like, well, I can give them some volume and some red cells, some oxygen carrying capacity. We're a lot freer with blood. And there's the arguments that blood transfusion is more morbid, causes mortality, but that's probably a surrogate for you've got a sicker patient that you're having to do all this stuff for. So anyway, all right, so you try to hydrate them up, get them off pressors if you can, and hopefully you don't get this far down to where they're occluding their vessels. The incidence is has decreased, but the mortality is still very high because, again, they're so sick from whatever they were already in the hospital for or in the ICU, and then you're knocking off their gut. So, per organ failure, you calculate about 25% mortality. So if you've got, cardiac and renal and all this, and then you kill the gut, that may be it. So it hasn't changed, but the patients have changed a little bit. They're not dying from something else earlier. So we have better monitoring and different ICU care, just in terms of fluid, and the ventilator strategies that we use now, just even in my career, has vastly changed. We're a lot more aggressive with fluids and nutrition and that kind of thing. And so some of the newer drugs, these are not new, but dobutamine and milrinone are used to kind of drive the heart, to help the flow. So kind of the 2-second talk about milrinone is a vasodilator, so the heart doesn't have to work as hard. And dobutamine is a inotrope, so it helps the heart beat more efficiently, more contractile. All right, so you have a drive with your pump to perfuse the periphery and the gut, brain, whatever you got to perfuse. So the risk factors, just think of any disaster in the ICU. That's the patient that gets this. So they're critically ill, sepsis, heart failure, MI, whatever. Something's bad wrong and they're in the ICU. They're in shock. They may have peripheral vascular disease, some kind of heart problem, arrhythmia, pressors. Cocaine is a pressor. Recent cardiopulmonary bypass and dialysis. You can think of those as that is a scheduled period of hypotension for that patient. And so they're already running dry. Dialysis, they'll be at home and all fine, and they dialyze them and then they're dry. So they're going to be walking around kind of vasoconstricted kind of immediately after bypass. And so they have a scheduled period of hypotension every other day. As you would expect, this is often a delayed diagnosis. You've got somebody sedated, intubated, delirious in the ICU, and they've got kind of vague abdominal pain. So you're called to see, is this ileus? Is this obstructed? Is this dead gut? So that's, of those three, you got to figure out. One's a nothing, one's a we can put an NG tube, and one's a disaster, intra-abdominal catastrophe. And so you end up, doing whatever you can, and you get a CT and your bowel's dead. That's easy to figure out at that point. They've got to go to surgery if they can even survive that. But it's kind of, until you get that CT, it's maybe a little bit vague what's going on. Maybe they'll have an elevated white count. They'll probably have an elevated lactate. They'll be acidotic, and they'll be hemoconcentrated. But, if they're so sick, maybe their hemoglobin's low, but they're concentrated on top of that. So, and if they could talk to you, it'd be pain out of proportion to exam. And so kind of the spectrum, we'll walk through these on the CT. Shock bowel, this is not dead. You'll see this in trauma patients. It's had a period of hypotension, and you get kind of this, I don't know, spidery picture, I would call it. But you have the hyperemic mucosa, is that what the bright is? Contrast in the kidneys, contrast in the aortas. And this is submucosal edema, so that's why it kind of looks, I don't know, kind of ferning in there. But that's okay. That's not great, but you'll see that. And that's, somebody that needs some more hydration, blood products, whatever. As it gets a little bit worse, you'll start getting pictures like this. And this is going to be a CT out of somebody from the ICU. And so I put these up together, and you can kind of, when you start learning to look for this, I'll show you a couple of things you need to see. So this bowel wall, this is pretty normal bowel wall here. Okay, you can kind of see the haustra come across a little bit. There's some contrast in it. But this, it's not here. This is all thinned out. This doesn't have GI contrast, or it hasn't reached this far. And so this is abnormal looking bowel. What you can also see in this picture, these are, it's a little bit different, but this aorta is small and contracted versus that one. Look how flat the cava is here. So this person's very hemoconcentrated. What you can also see too, and it's one of those subtle things, but you'll learn to look for it. These are pretty normal mesenteric vessels. Look at these, they're just little specks. So this person's really hypovolemic and really clamped down. Over here, this bowel's gone. You don't have any, really, normal bowel, you can kind of see the wall. Over here, you really can't see the wall. There's some local fluid and everything. So this piece over here is dead. Probably all of this is dead. Here it is when it even gets worse. Pneumatosis intestinalis. This is going to be an even later finding. You can assume all this is dead too, but sometimes it's kind of subtle, but in a bowel obstruction or something like that, air is going to go to the top. So if you look for bubbles on the bottom or circling around the edge of bowel, that's pneumatosis. Okay, bubbles should rise to the top. These little tiny air bubbles that outline the wall, it's pneumatosis. So this person needs an operation. Again, it may be an autopsy. And even further down the road, this would be bad. This is a really kind of cool picture. This is bad. But you've got this ferning where the portal vein is filled with air, free air here, free air here. So this would be bad. And this is just set on a different window, but a bunch of air in here because the bowel downstream is dead. This is gut bacteria making a bunch of gas that goes up the portal vein. But anyway, that's pretty cool, but pretty bad. So your goal of treatment is save the bowel. You may not be able to do that. You want to restore intestinal blood flow as quickly as possible. This is not a bypass. This is hydration, blood products, whatever. And so you try to volume resuscitate them. I think the easiest way to resuscitate somebody now is a flow track. I mean, that's within minutes. You can see that something's happening. Try to get off pressors if you can. Again, that may not be so easy. Milrinone or dobutamine to improve your cardiac function. Feed the pump, make the pump work better. Treat your underlying illness, which you should be doing already. Antibiotics to cover the gut if they're not on that. I mean, this could happen with somebody with pneumonia. You know, they're so sick and hypotensive and surge from all that, sepsis, to where they'll be on that. But you need to cover gut bugs, gram negatives, and an NG tube, NPO, to try to rest the bowel. You don't want to tax it anymore. You don't want to give it any metabolic load in addition to it's just trying to stay alive. If you suspect or find pneumatosis or free air or something like that, you need to go to surgery. Try to resect that. But I mean, regardless of what you do, mortality is probably close to 90% because they're already so sick from whatever it was. And now you've added a laparotomy and a big bowel resection and all the inflammatory mediators that are spilling out of this dead piece of bowel. So nonocclusive mesenteric ischemia is kind of the worst survival of the gut ischemias because the other two are kind of an acute problem, especially the embolus. You know, hopefully their heart's not too bad and they're kind of okay, and then they have this insult. But okay, that's where I'm going to stop for today. And next week we'll cover small bowel adenomas and stuff. Any questions? So 3 ischemias, okay, embolic, thrombotic, and nonocclusive. That's it, intussusception. Okay? Read the Savastin textbook. It's tough. There's probably, I would say, nearly half of that chapter is about Crohn's. So I don't know who got the Crohn's lecture, but it's tough. But anyway, read Savastin and pass your absite and board. Okay. Thank you.